signs have been coming up in the bottom of the screen that the volume is low, so I'm going to speak as loud as I can. I have a vocal cord paralysis from surgery, and so I may get hoarse by the end of the presentation. But what I would like to do is go ahead and start. The topic is airway compromise in the neonates, and this is something very dear to my heart too, Fatima. I've been doing this for almost 40 years, and I essentially only do newborns, and I really kind of concentrate in difficult airways. But my first experience with the Indian Medical Association was with Dr. Gaya, O.P. Gaya, and I contributed to the 5th edition back in 2020 with him, and got to meet him in Memphis for a while. Also, I want to thank Raji for allowing me to participate in his book as well. Some issues in otolaryngology and in dealing with neonates you can prepare for, but others you can't. And let's talk with the goal of the topic is to talk about the anatomy, the nature of the larynx, prenatal discovery, postnatal identification and management, and then the types of stridor, your interventions, the role of innovation, ventilation, and management and surgery. The nature of the infant neonatal larynx is completely different than the adult. It's 1/3 of the size. It has a very small anterior posterior diameter of only 7 millimeters with a width of 4 millimeters. And the subglottis is the narrowest cartilage in the airway. It is the restrictor, and also the most likely to be a source of problems in the neonate who's been intubated. Although some children can be born with congenital subglottic stenosis. Obviously, the infant's larynx is smaller in proportion to that of the body than it is to an adult. The head is larger in a newborn than in an adult, proportionally to the body. It is really important.
Jerome, sorry to interrupt. Are you sharing your screen?
Yeah, I am. Let me go back.
Yes, please.
Double check.
Because we are not seeing your screen yet.
Okay. Let me go back and do it again. Okay.
Yes, it's fine now. Thank you.
Okay, going presentation mode. Try again. Okay. And there you go. All right, how is that? Is that better?
It's good now. Thank you.
All right, excellent. Thank you for letting me know. So anyway, and there were no important pictures anyway. When you're dealing with trying to establish a good list of differential diagnoses and pediatric airway problems, you can sometimes get into a long, boring list. I've tried to introduce some photographs of some of the challenging children I've dealt with to try to break the monotony of giving you the list of differential diagnoses. Starting. Okay. All right. Anyway, the anatomy and endotracheal tubes, things that can cause obstruction, pyramidal aperture stenosis, tumors, encephalocele, and septal deviations. When you're intubating, there is a desire to nasal intubate because of the stability of the airway. When you do that, some tricks. We heat the endotracheal tube up so that it's soft and flexible. Otherwise, you'll get bleeding because you'll spear the adenoid in the back. And contrary to popular belief, we put the endotracheal tube not in the bottom of the nose, but pretty much in the middle, so we can glide it between the middle and inferior turbinate. This is anterior pyramidal aperture stenosis. This is the Tom Cruise disease. This is where the midline of the face does not open up and the nose doesn't open, and they have one large central incisor. They are born essentially with the same symptoms as choanal atresia. They're not able to move air through their nose, and as you know, newborns are obligate nasal breathers for the first 6 months. So this has to be surgically opened. Some children occasionally are born without a nose. This is a child who was born without a nose, not kindly referred to as a cyclops. The eyeballs are fused. There is no nasal cavity. This photograph was shot in the complete darkness of the room. Nasal oral encephaloceles are challenging because, one, you have to push the encephalocele out of the way to secure the airway. And they can have more than one. This child had 2 encephaloceles. And it was a challenging airway. The one in the mouth had no viable brain tissue, and we simply amputated it with the neurosurgeons at the delivery. I use an anatomical approach when I discuss airways, oropharyngeal airways. Obviously, there's Pierre-Robin sequence, tumors, and encephaloceles, as I showed you, but we also deal with cysts. And cysts in the airway can be extremely dangerous. And other congenital anomalies of the tongue, such as a duplication of the tongue or Beckwith-Wiedemann syndrome, which is chromosomal abnormality where they have a very, very large tongue that sometimes makes their management as a neonate difficult. And also Friedman-Sheldon syndrome, also called whistling face syndrome. We also have had to deal with an immediate post-op period with umbilical cord wraps or an amniotic band. There is no nasal or nasopharyngeal cavity. An old pediatrician taught me a way to help manage these children. A very large red rubber Robinson orogastric tube will break the surface tension between the tongue and the posterior pharyngeal wall. And then they can breathe along the sides of the oropharyngeal tube while you're getting a chance to get an endotracheal intubation. This is a child that was one of our exit procedures that was born with the duplicated pituitary, an aborted twin attached to the palate, and with 2 tongues. It was very interesting. We're in the process of, during electromyography, to decide which parts of the tongue to keep. This is one of the more common ones, Pierre-Robin. At our institution, we distract the mandible to open up the airway. We no longer trach these children as we used to. This is Friedman-Sheldon syndrome, Whistler's face. There is no oral cavity. It's just about the diameter of a soft drink straw, soda straw, going all the way back to the glottic opening. It's associated with arthrogryposis. Getting back to the anatomy, and again, near and dear to my heart because of my vocal cord paralysis, obviously the tongue base is frequently a problem in older children, but not as much in children. Epiglottis for laryngomalacia, the opening of the larynx, the introitus, the piriform fossa on the sides, and the trachea. Notice the back of the trachea is membranous. That becomes important when we talk about children with Down syndrome. As you can see, I've highlighted here the subglottic area. This is where the problem arises. Because of the cricoid cartilage being completely circumferential, it limits the blood flow to the submucosa circumferentially. So a large endotracheal tube or a cuff pulled up in this area will essentially strangulate the tissue. What I'd like you to do now, kind of an exercise, you're all sitting down, place your hand below your waist at the side of your chair, and then take your thumb and press deeply into your palm until it blanches. Then when you let go, you'll see the capillary fill coming back in. Certain endotracheal tubes and certain trach tubes allow for capillary fill, others don't. And that's what causes severe necrosis. We see it all the time, large endotracheal tubes, but you sometimes need large endotracheal tubes for ventilation, as Rajiv can tell you. All right, and so continuing on, we have problems with the vocal cords themselves, paralysis, cysts, webs, tumors, atresias, and agenesis. And I'll show you a picture of our agenesis child. And subglottic hemangiomas are getting to be more common. The subglottic stenosis wasn't a problem in the 50s because we didn't intubate that many children. But with the advent of sophisticated ventilators, we were able, and with better intubation techniques, we were able to save a lot more children by having better ventilators and better endotracheal tubes. Ultrasound has broken the neonatal care world into 2 periods, as far as I'm concerned, as far as dealing with airway compromise in neonates. Now there's a period in the prenatal period where we discover things we never would have discovered before without the 3D ultrasounds. Congenital anomalies are very often detected very early. And if you combine it with other modalities such as MRI, CT, and ultrasound, we have a really good idea of what the prenatal lesion is going to be. Some of the things we've discovered prenatally: epignathic teratomas. I have about 16 of these now. Foregut cysts, teratomas, vascular lesions, endotracheal lesions like the Tracheal, laryngeal agenesis, and fistulas. And we can see these prenatally now, okay? This is a series of 3 epignathic teratomas that we saw. The one on the left is an aborted twin where there is significant necrosis. The one in the middle, very little necrosis, and that's the brain case that I'm holding. And on the far right-hand side of the screen, you can see an empty brain case after I deflated the amniotic cavity. This child was easy to intubate when we grabbed the cyst, drained it. You can see the stab wounds at the bottom of the cyst. The stab wounds penetrated a rudimentary kidney, and we were able to drain the urine and amniotic fluid out of the center of the cavity and just pull it out of the way and intubate. The ultrasounds allowed us to see some wonderful things preoperatively. As you can see on this ultrasound on the left, you can see there's a large oral cyst. Here's the facial view in the middle ultrasound. And on the right, you can see me learning a very important lesson. Nature has put a Burnix on the surface of babies. It is a great insulating material. You can wipe it off, and believe it or not, there's still a microscopic film which will not allow you to ground your bovie. So a monopolar bovie will not work on a newborn baby. And as I found out, and as you can see, I'm trying a monopolar here. The next photograph, which I'm not going to show, is me getting frustrated and using a pair of scissors to drain it and pull it out of the way and intubate. I'll show you that later. Here's after it's been drained. Being an old-fashioned doc, I was taught by Seymour Cohen, one of the first 2 pediatric ENT docs in the world, that if you can put your finger in a newborn's airway and feel the larynx, you can intubate it. So that's me feeling the top of the larynx, feeling the epiglottis, and feeling the introitus of the larynx. And then the one on the right shows the cyst open with a Penrose drain in it, and listening for tension pneumothorax, because sometimes people get really excited and really stressed and their adrenaline's really flowing, and we've had a series of tension pneumos. This is a thyroid teratoma completely occluding the left carotid. This is a vascular abnormality. This child only lived for about 8 hours. Another exit procedure. Just to talk about the other things we can see on ultrasound now that we're looking for them, the different types of esophageal fistula and atresia. This is my child with the laryngeal agenesis. This child had, you would think those are vocal cords. They're not. They're just kind of mesenchyme remnants when you biopsy them. And there's no lumen, and you can see NG tube going down into the stomach, but there is no opening to the larynx at all. This is what we found when we went in surgically, and we found it was correlated to some studies in rat agenesis of their larynx. And they presented 3 different types. Ours turned out to be a combination of all 3, but closest to number 2. It was a solid cylinder. And then when we cut the cylinder open, we found unorganized mesenchymal tissue in the center of it, very similar to a Tootsie Roll. We were able to hollow out that cavity and use that as my lateral walls, and then we reconstructed with 2 large rib grafts on the outside. To keep him from aspirating, we made the very top, where the vocal cords would have been, lined with a skin graft, so it collapsed. And so making essentially closed lips for the upper airway, so we have a competent airway. The exit procedure really was created for congenital high airway obstruction syndrome children. It's a controlled C-section. And the hardest thing in the world is to paralyze a mother. And then when the baby is delivered by C-section, to paralyze the baby. We're all taught not to paralyze a child, because if you paralyze them, they lose their ventilatory drive and you may not be able to secure their airway. It is a one-way ticket, and it is a very tense situation. So we paralyze the mother and the child, and we deliver the baby either halfway out and have the OB/GYN hold them in their uterus to keep the lower half of their body warm and not to strain the umbilical cord. On some of them, on ultrasound, we can see we have a very long umbilical cord. And so we'll deliver them all the way out and take them either off to a tray to the side or operate on them on a tray laying on the mother's padded legs. We try to bronch them if we can, we try to intubate them if we can, and if we can't, we trach them. And here again is another view of me with that foregut cyst on an exit procedure. And you can see the OB/GYN holding the baby, pulling the baby back into the uterus. With the paralytic, we paralyze the uterus, but they tend to slide out anyway. So you have to hold them in place. On the scene on the image on the right, you can see the OB/GYN getting ready to clamp, receiving the clamp to clamp the umbilical cord after we secure the airway. Now, let's go to the second phase of the child with a compromised airway, that of the post-delivery infant, and you're now presented with an airway obstruction that you really didn't have any idea was coming. And you have a child, and the most important thing is to look and listen. And that's the hardest thing for my residents to do. They are surgeons, and so they want to do something immediately rather than take a second and listen. And by listening, you can learn so much from a baby's airway. I just saw a child from 2 institutions. The mothers are wonderful people. They know in their heart and soul what's right for their baby. This mother had gone to 2 major institutions with her child and told them her baby wasn't breathing right, and they told her the baby was normal. They brought the child into the room, and we just sat there and listened, and we could hear a bilateral cord paralysis. And the child had had an open airway, an unusual paralysis with an open airway. He was able to move air, but when he breathed in, he sucked his cords together. So when they scoped them, he had a lot of mobility, but it was paradoxical mobility, and they had missed the diagnosis. So there's inspiratory stridor predominantly above the cords, to and fro, biphasic stridor predominantly at the lower cords or a little bit below, and expiratory, which is below the level of the cords. This is the classic fluttering inspiratory stridor of laryngomalacia. It's hard to get a really clear shot of this when they're breathing at about 120, 130 times a minute. It's fluttering in laryngomalacia. There's an argument whether it's neurological or physiological or anatomic. There is a 20 to 30% association of gastroesophageal reflux with this, so that supports the neurological argument. But it really, really is amazing to see the arytenoids prolapse in and the epiglottis assume a scroll or a tubular shape. Sometimes the children are only breathing through that small gap between the arytenoids. Another cause of biphasic to and fro stridor is subglottic hemangioma, webs and subglottic cysts. This is a hemangioma on your right screen. This is a pyogenic granuloma from post-intubation. When you intubate a child, sometimes within weeks after extubating them, the endotracheal tube has closed off some mucus glands that then continue to secrete mucus and produce a large infected mucus cyst. These are laryngeal webs. They're very thin, just very thin membranes. Seymour Coyne, the gentleman that trained me, again, one of the first 2 pediatric otolaryngologists, classified these as type 2 and 3 webs. Class 4 is a complete, and I've seen one of those. All right, I have a video for you if everything works. And here we go. And this is high-pitched inspiratory crowing stridor of a bilateral cord paralysis. And if you listen closely, there's also an expiratory phase. Okay, vocal cord paralysis, which is near and dear to my heart. Tomorrow, my voice only lasts till about noon. I'm so glad we're having this lecture this morning because tomorrow morning at 8 o'clock, I'm getting a thyroplasty where I'm having my vocal cords medialized because I have no voice after noon. And so with pediatric cases, they often resolve spontaneously. And so you don't think about doing reinnervations. And we've developed new techniques for managing vocal cord paralysis. 10% of them are congenital lesions. Here's the most interesting one, and I put the questions here because you cannot condemn another colleague. 30 to 50% of these are idiopathic, and we're going to discuss what idiopathic really is. 15 to 25% are associated with neurological disease, and only Arnold-Chiari and hydrocephalus respond to improve over time. Meningomyelocele don't tend to improve. All right, let's continue. Bilateral cord paralysis is just slightly more common. And unilateral, if you have a unilateral, is more prevalent on the left, which is to be expected. The left recurrent nerve is 1.5 times longer. It loops around underneath the aorta, while the right loops around the subclavian artery and then recurs up to the larynx. The left recurrent nerve is associated with cardiac abnormalities, which therefore require cardiac surgery. The recurrent nerve is about 5 hair diameters. The diameter of 5 human hairs wrapped together as it goes around the aortic arch in a newborn. It is impossible to see. The thoracic surgeons try to go where they think it is not because they can't see where it is. Okay, the types of vocal cord paralysis. Let's talk idiopathic. Idiopathic has no proven etiology. How many of you have ever watched a video of a vaginal delivery where the OBGYN was extracting the baby either with a suction extraction forceps or with their hands and really pulling on the head and stretching the neck? The baby's necks are meant to be stretched. They're fairly elastic, so they usually survive it without any injury, but we still see Erb's palsies. And the idiopathics probably are due to torsion. 80% of bilateral paralysis in the newborn respond and recover completely. Let's talk about the idiopathic. Breech deliveries are probably the most common that we see where the nerve is elongated when the neck and body are torqued to deliver the head, sometimes with just rotation or with an inversion technique. With C-sections, they're using such small incisions to prevent uterine rupture using the Fenton steel, very low bikini cut, that they make the incision in the uterus really small. So they really have to pull hard to get the baby's head out. Shoulder dystocias, as I said, one of the most common areas where we see both an Erb's palsy of the neck and a recurrent nerve injury, usually on the same side as the Erb's palsy. Forceps delivery, that's a compression of the facial nerve, of the recurrent nerve as it comes out of the skull base. The skull base is very soft, and high resolution CT scans can show the crush injury of the skull base, and you can see the forceps injury there. 75 to 100% of these recover spontaneously within 6 to 9 months. Getting back to to and fro stridor, vocal cord paralysis. It's a globalized world. We're seeing congenital syphilis, we see varicella zoster infection, CMV, causing vocal cord paralysis, meningitis, bacterial meningitis, and viral encephalitis, all causing vocal cord paralysis. The expiratory phase means that it's below the vocal cords and it's compression of the trachea, either a vascular compression or a mass. Many of our foregut cysts that we discovered were discovered on CT scan or ultrasound showing a compression of the esophagus. There are also malformations of the trachea, the tracheoesophageal fistulas, and that really can compromise a child's airway if all their stomach contents are coming up into their trachea, or the reverse, if their trachea is ventilating their stomach instead of their lungs. Stenosis of the trachea, complete rings. Complete rings, again, in the pediatric community, the older pediatric community. When I was a resident and an intern, we took turns bagging these children because a ventilator couldn't ventilate them because it couldn't generate a high enough pressure. With complete rings, the distal third of the trachea, instead of having horseshoe-shaped rings, have complete circular rings that connect to each other and do not grow with the baby. So within the first 30 days in the neonate's life, the lungs outgrow the ability of the trachea to deliver air. And so we used to hand ventilate them. When the ventilators failed, we took shifts hand ventilating them, hoping that somebody would come up with something, and then we had to let them go. Now we fight and we win. We do corrective surgery. I'll show you some of them in a second. We've also just written a paper about balloon dilating. One of our children, a child with Down syndrome with a very severe congenital heart, the child was too small to undergo heart surgery, and he had outgrown his airway by the end of the 3rd week. And so faced with a child that was suffocating, we couldn't ventilate him, the endotracheal tube, when you have a tight stenosis, how many of you have noticed when you put an endotracheal tube into a stenosis that the stenosis obstructs the beveled part of the tip of the endotracheal tube, obstructing your airway? And so you find that you're forced to pull the endotracheal tube back from the stenosis and inject the ventilation through the stenosis. We were losing this child, and with no surgical options, I ballooned him and broke the rings. And we're reporting that in the laryngoscope coming up. We used first a 5, then a 7, and then an 8 laryngeal balloon dilator to break the rings, and we maintain them. The child is 9 months old now, and going ahead to have the heart surgery. Children with Down syndrome. Again, back in the old days before you had IRBs and things like that, we would do autopsies on our children who didn't survive to find out what was wrong. And in several of the children with Down syndrome, we dissolved everything but the rings on the trachea and found that the rings are spiral in children with Down syndrome. They can expand because they don't connect, but they overlap each other like this in the back. And so that is very interesting. We also found that compared to other cadavers, that they had 1 ring less. And that makes a big difference when you use a formula to calculate how deep to put your endotracheal tube, because the formulas don't take into consideration that 7 millimeters shorter. That one ring is 7 millimeters in width. And so children with Down syndrome have 1 less ring, and therefore their carina is 7 millimeters more proximal than you think. All right, this is an expiratory stridor. It was an innominate artery. Notice how it's diagonal. That's the artery coming off too far off the aorta. And so it has to bowstring and come back toward the anterior neck. And as it does, it puts a dent in the esophagus and the trachea. And also vascular rings do the same thing. Here's for Fatima, here's an endoscopic view of a double aortic arch. It's at the level of the carina. It is a complete arch. And this child is roughly 1 month old and was having dying spells. And this was an 80% compression. Here's the picture of the complete tracheal rings. The blue circle shows the diameter of the normal trachea. And in the distance, you can see the distal 3 rings are completely constricted. They never grew. They are at probably a fetal diameter, and a diameter of a preemie in a full-term baby. And that's what we broke with the balloon. Now, in managing obstruction, the diagnosis is critical. You really have to know what you're dealing with. The clinical exam cannot be overemphasized. A history of events during the pregnancy are important, but listening to the baby and listening to the mother talk are really important, because you can find out so much before you even get to the operating room to take a look, or in the procedure room to do a flexible bronch. In Fatima, I do a lot of flexible bronchs, removing blood clots from lungs and things like that. So I'm impressed with flexible bronchoscopy. Anyway, with the imaging capabilities we have now, that should be part of the workup. An angio saved me from making a horrible mistake on one of my exit procedure babies. The baby that you saw that had the 2 tongues had a huge aborted twin attached to the palate. The blood supply is usually through the sphenoid bone, but we didn't see that. We saw stock, but we did an angio and the artery was coming up out of the tongue. If we had tried to resect this in the delivery room, we would have killed the baby, because this was the blood flow coming to the aborted twin was larger than external carotid and equal to the internal carotid in diameter. Now, flexible fiber optic nasopharyngeal laryngoscopy and flexible bronchoscopy have important roles. They complement each other. I like rigid bronchoscopy and rigid laryngoscopy for securing the airway. And in one of my children, the child that was born with laryngeal agenesis, the lungs were hypoplastic. They were full of fluid because they had never been able to circulate the normal pulmonary fluid that's inside the lungs. I'd never thought of that. We almost lost the kid on the table because when we delivered him, we were celebrating victory that we were able to trach him within 4 minutes. And then we almost saw victory taken away from us because we couldn't ventilate him. His lungs were full of a congealed fluid, a gelatin, that plugged every sucker we had. We went through all the surgical suckers. We started using anesthesia suckers. It was too thick to go up the suckers, and so we started cutting the ends off of plastic suckers. We were able to get them out. And we're going to talk about innovation. Going through 15 or 20 anesthesia suction catheters from almost every operating room was the only way we were able to save that child. And then we got tension pneumos, but the tension pneumos I'll explain later. Okay. That's interesting. I don't know if you can see it, but I see yellow lines on my screen. Endotracheal tubes are a major important part of managing children. Cuffless is preferable. Sometimes with bad BPD, you need a cuff. But there's a problem if you trach these children, and I'll tell you about that in a minute. Use a smaller size than you would guess, because our biggest problem that we see with children that make it out of the neonatal period is subglottic stenosis from the endotracheal tubes. Down's children are very, very different. They have a very high incidence of congenital subglottic stenosis. So if you put the appropriate size tube in them, it'll be tight and we will get a complete laryngeal stenosis. Remember, the endotracheal tubes move every time the ventilator cycles. And so it's kind of a vibratory sawing motion against the subglottic area. So you need to be aware of that. Cuffs in most endotracheal tubes, except the new silastic ones, are non-compliant. They're made out of PVC. And when they inflate, they're rock hard. They deprive the submucosa of capillary blood flow, and it causes submucosal damage, mucosal necrosis, and we get circumferential scars in the cricoid area. Remember, the cricoid is the only completely circumferential cartilage in the airway. The thyroid's not, the tracheal rings are. The cricoid is a complete ring, and so it compromises the blood flow. Head position is critical with intubation. I'm going to show you the next slide. And use a glide slope when possible, but remember, a straight rigid, when you fail with a glide scope, a straight rigid through the corner of the mouth, and I'm going to share with you my greatest trick. You know, when you intubate someone, you intubate in the middle and you lift the tongue up with a Mac blade or with a straight Miller blade. I don't do that. I go through the floor of the mouth. I push the tongue back against the palate, go through the floor of the mouth, and go into the airway sideways, and then slide over into the larynx. The tongue in a Pierre Robin is your biggest enemy. The tongue is a normal size tongue in a very small mandible. There's no way you can easily intubate them unless you slide the laryngoscope off to the side. And a glide scope's a little bit too big to do that trick with. So a very small Miller is sometimes the best way to intubate a Pierre Robin. Now, the head position is critical. The vertical line is the line of demarcation where the carina is. If you flex a child's head, an infant's head, and mothers want to do that, nurses want to do that, NICU nurses want to do that because it looks more comfortable. It makes the child look more comfortable to have a pillow under his head. What that does is it pushes the endotracheal tube down up to 1 centimeter, further down the airway. If you're already close to the carina, if you flex the head, it will go down in one of the main stems, or even worse, hit the carina and cause bradycardia or granulation tissue. When you extend them, particularly with an endotracheal tube and a trach tube, it floats the trach tube into the middle of the lumen and pulls the end of the trach tube back from the carina. Okay. I really wonder what those yellow lines are. Anyway, balloon dilation with subglottic stenosis, complete rings, and almost any stenosis is a technique that's just developed in the past few years. It's really, really worked. We're now doing cricoid splits for vocal cord paralysis and subglottic stenosis. We do for severe cricoid, for severe subglottic stenosis at the level of cricoid, we do cricotracheal resections. For extended tracheal stenosis involving the larynx and the subglottic area, we do laryngotracheoplasties with rib grafts. For mid-tracheal lesions and lesions down near the carina, we do slide tracheoplasties. We do laser resection of some subglottic stenosis, a little bit at a time. And we do laser notching of a subglottic stenosis so we can balloon dilate it. And we also apply mitomycin to inhibit scar formation. We just did a study in newborns. 123 patients. In 123 patients, what we did was we balloon dilated them up to 3 times. And 35% of those still required a tracheostomy. But 65% didn't. So we were able to decrease our incidence of having to do tracheostomy for subglottic stenosis by 65%. And that was significant because there's a lot of morbidity and mortality associated with prolonged tracheostomies. And here is a cricotrichoid resection where we cut out the cricoid and just sew the trachea to the bottom of the thyroid cartilage. Here's a laryngotracheoplasty with a rib graft. Here's one of my rib grafts. It's very hard to put a rib into the trachea without getting an air leak. As you'll see, it doesn't look like a straight piece of rib on the right-hand side. That's muscle I pulled in to seal the leakage so that the rib graft won't leak and get air in the neck. And we also now use tissue glue too. But we can we can double the lumen of a trachea with a rib graft. Now, the laser for me is an important instrument. The view on the left is what I saw when I took a baby to the operating room who was in respiratory distress in the delivery room. And by hyperextending their neck when they were bagging, they were able to bag him and move him over to our hospital right next door. And we took him to the operating room. And when I put my laryngoscope in, I saw this large molecular cyst. And you do not see the larynx. You can't see the larynx. And we were just barely blowing air in. Here's the laser debulking it. And when we broke it open with the laser, it drained and we could see the larynx. And on the right-hand side, you can see the collapsed base of the molecular cyst coming from the left part of the vallecula and a normal epiglottis. Of interest, this child had a duplicated esophagus that we found later. Here's a slide tracheoplasty, which I just did this week. You can see we diagonally cut the trachea and then slot the front and slot the back, and then we slide them over each other. When you do an end-to-end in a circular cut, all scars heal circularly. And so no matter how good you are, when you sew them end to end, you get stenosis at this site and you have to balloon and try to redo it again. If you do it diagonal, you get an oval stenosis, which doesn't produce as much obstruction. The cricoid split was originally created for subglottic stenosis. You would open the neck, cut the cricoid open like in the first image, a little bit to the left, and you would put a large endotracheal tube in and stretch it open, and you get a fibrous deposition between the two vocal cords. and it would work about 80% of the time. Now we're doing everything endoscopically. And as people want to find a way to do something without doing a trach, we now, even if we have a bad bilateral vocal cord paralysis, we don't trach them. We take a sickle, we take them to the operating room and take a sickle knife, and we do an endoscopic cut of the cricoid ring up to the level of the vocal cords. We balloon dilate them up to an 8, and then we put a 4 endotracheal tube in. And these are newborns. And when we leave it in 5 to 7 days, enough for a fibrous deposition to form in the gap, and then we pull it out, and they have an adequate airway. And so we've been able, that was popularized by Dr. Mike Rutter in Cincinnati, and it has become a very popular way to manage vocal cord paralysis. Ventilators are an important tool. Rajiv, you and I both know this. We love ventilators. Trach tubes can help with ventilation by decreasing dead space, but there's always a challenge. Fatima can tell you this. There's always a challenge between the ENT doctors and pulmonary because they want a larger tube. And we're just now getting to the point where we can give you a larger diameter tube without going down the main stem. The problem is with Bavonas and Shileys, they go up by 1 millimeter in diameter, but they don't go, the length is rather irregular. And from going from a 3.5 to a 4, it goes 1 centimeter longer. And so you may need that 4 for ventilation, but if you put the 4 in, it's going to be right main stemmed. And in some children like Downs, it is already not right main stem. And so we put spacers in and we order custom made tubes. Tracheal now has the ability to provide custom made tubes within 3 to 4 days, custom delivery. Bavona trach tubes. Now, regular endotracheal tubes are made out of PVC. Bavona and Tracheal are made out of silicone. Silicone allows for capillary blood flow. And so the Bavona and Tracheal, and I have no financial interest in either of these companies. I was just glad to see them come up with something that stopped hurting children. So anyway, these cuffs fail at 35 to 40. When you blow them up, they turn into a sausage and not a big round ball. And so if you have a baby with severe BPD, who's going to need a pressure of 50 to 60 to ventilate, the Bavona and Tracheal will fail. They're not designed to hold airway pressure of over 35 to 40. And if you need that, a Shiley trach tube with this PVC cuff can hold 50 to 60, but it'll leak at 60. Endotracheal tubes may be your best choice. The conclusion. My goal was just to give you a better understanding of airways and airway compromise by showing you some of the anatomy, elaborating on the most frequent cases, and giving you a better awareness of the stridor and its significance and taking the time just to listen. I talked about the medical and surgical managements, and I wanted to give you an awareness of how to optimize your use of ET tubes and trach tubes. Because, you know, pediatrics and pediatric subspecialties are a special calling. You know, it takes special people to do this, to deal with crying and dying babies. You're doing the most rewarding job in the world. You really are, every day. Every day you go to work, you make a difference in the world by helping a neonate, a child. And I took out even a teenager, because I have a teenager that's very trying. But I want to applaud you for what you do. And I want to thank you for the opportunity to speak to you today. Thank you very much. Rajiv.
Thank you so much, Dr. Jerry, and it was an excellent talk, and appreciate it even more because of your operation tomorrow. Best wishes for that. You're so brave to be here today, to be speaking to us when you have a surgery tomorrow. Dr. Fatima, do you want to take? Yes, please.
Thank you very much.
And sorry for the interruptions in between. I mean, we have to work on this issue of people annotating. So it happened with me once, but I should have learned from experience.
I thought it was my computer. I'm glad it was somebody else doing it.
They should have erased it, but they didn't. Thank you. Dr. Fatima is there. Dr. Fatima, please take over.
Yes, I'm here. Thank you so much, Dr. Jerry, for the excellent talk. I want to applaud you for the amazing work you're doing on daily basis. And I wish you, as my colleague, Dr. Stirad, a speedy recovery and best of luck tomorrow for your operation. I'm actually speechless. It's like a magic, like, you know, taking the baby from a situation to totally another one, giving them another life. It's amazing. I do a lot of collaboration with our ENT team and Dubai Health Authority. And we do have a colleague who do tracheal reconstructions as well. He do an amazing work, but I think we do need to collaborate worldwide for these neonates and these babies and do a much better work all over the world. I mean, we shouldn't specify it to a specific place. When we do have the knowledge and we do have the ability, I think we should spread this knowledge all over the world. And this is what you're doing, Dr. Jerry. It's amazing. Thank you so much for your talk. And you have added a lot of knowledge to me, to myself, and I think lots of other people had lots of benefit about your talk. And I think we need to rethink about the diagnosis, the proper diagnosis of these neonates and how to manage them appropriately. Time is crucial, especially when it comes to these small neonates and dealing with airways. Handling them appropriately is very crucial. I don't know, maybe we should take some question from the audience. I would leave that to Dr. Sridhar or Rajiv, please.
Don't see any questions from the audience at the moment. It was very interesting, Dr. Jerry, about the cases you explained and the endotracheal tube. I mean, how much it can play a role. The fascinating part about the Down syndrome babies, how their anatomy is different. And obviously the exit procedure itself. So among the exit procedures you have done, which one was the most intriguing or the most difficult? I know all of them are difficult, none of them is easy.
Well, the most difficult was the laryngeal agenesis, because even though we knew what the rat embryology was, we didn't know if it correlated to the human. And when we won the exit procedure where we almost lost him, that baby was so dark and the blood was so dark, and the OBGYN had his pulse, his finger on the umbilical cord, telling me that we still had blood flow, and I couldn't believe it. But the period of trying to get that jelly out of the kid's lungs was the most terrifying moment in my life. The second phase was when we did the surgery a little bit later, and at 18 months, and reconstructed him. When we, you know, part of my talk was about innovation. This child had had an attempt at another institution at a fatal surgery with passing a wire through the larynx to try to dilate and open it. They didn't know, and I didn't know, that it was a solid cartilaginous cylinder. And so the wire bounced off and actually went down in the lung and perforated the right mainstem. So when they transferred the baby to us, you know, the fetal ultrasound showed no problems in the lungs. And so when we got the jelly out of the kid's lungs, and remember I said people get very excited when they ventilate these babies. We were mass ventilating them, and we had attention pneumo. And so that's not uncommon. And so I put in chest tubes real quick. And then over the next 2 weeks, the attention pneumos didn't resolve like most of them do. So I bronked him and found 3 little holes in the right mainstem, which were actually a little bit larger than the diameter of the dilating wires that had been placed at the other institution. And so innovation is really important. If you have a dying child, you really have to use the resources of all of your training and step outside the box. So in urology, they use a very long needle through the urethroskop. I guess that's what they call it. And they inject deflux into the bladder wall to close. The thoracic and general surgeons said they couldn't reach those. They would have to go in and do a thoracotomy and didn't know if they could even find them from the outside. So again, I was stuck with no one willing to do an open surgery. And so I took a bronchoscope, one of the really high quality Storz bronchoscopes, and under video guidance, I was able to pass a wire needle, a deflux needle, through the suction port, and was able to inject the orifices with Prolarin. Now, I had already had 2 or 3 Prolarins myself, so I was familiar with the injection of the larynx with Prolarin. And so I injected Prolarin into the openings of those bronchopulmonary fistulas and closed the leak. And so we were able to pull the chest tube. And so when we opened up this child's larynx, the child was just an amazing stream of just challenges until today. And so the bottom line is, when we opened him up, we decided to use that empty cavity where the mesenchyme is in as a laryngeal lumen, and it worked. So that was the most challenging.
Dr. Sukumaran, I think your audio is on. There is one question from Dr. Tushar Kulkarni. So a neonatologist who is at the delivery has incidentally discovered airway obstruction. Sorry, I'll just try. Dr. Sukumaran. Apologies for this.
Oh, no.
I'm trying to find him.
This happens. This is the nature of Zoom.
I'm not able to find him. Anyway, I mean, the question from Dr. Tushar, who is a consultant in Latifa Hospital, is if a neonatologist who is attending the delivery suddenly discovered upper airway obstruction and the ENT surgeon is on his way, how does the neonatologist tide over the crisis till the ENT surgeon comes? So basically, would you recommend a cricothyrotomy or something in this scenario?
Well, again, it depends on where the lesion is. Now, a cricothyroidotomy is an easy operation in an adult. It's a little bit harder in children. I've had to do a couple within 30 to 40 seconds. If you've done one before and realize how small everything is, it's probably the best thing to do. If you cannot intubate, a cricothyroidotomy will save a life. But you have to have practiced it, and I know this really sounds sad, but you need to go down to the morgue and actually do it on a fresh cadaver, because the trachea collapses and even the cricoid will collapse on you. So as you're cutting into them, you can hit the back wall. So long as you stay in the midline and make vertical incisions in the midline and you trap the trachea between, I'll try to do it this way, you trap the trachea between your fingers and you cut straight down on top of it, you're safe. And we can repair any damage that's done. So don't go into it worried about what you're going to do, what damage you're going to do. Go into it with the knowledge that you're going to save a life.
So in your team, have you encountered anyone doing it, a neonatologist doing it, and what did they use for it? Is it a large gauge Venflon they used, or? Well,
the last one I saw a neonatologist do it, they did it with a 15 blade. That's the typical surgical blade that we use. And the incision was high, and that was actually fortunate because they actually cut into the thyroid cartilage and the cricoid. And that made intubation easy, and it actually made the repair easy. And so all in all, it turned out very well. I've seen 2 neonatologists do it, and they did a very good job. But a needle puncture is almost impossible in this young of a child. Doing a needle cricothyroidotomy, the distance is about 3 millimeters from the front wall to the back wall. It is very hard to hit that space. It's much easier to make the cut. And there are very few vessels in the midline. There are the blood vessels, tiny blood vessels going to the cricothyroideus muscles in the front. They're off laterally. If you're in the midline, there are very few blood vessels there. And if you have suction or at least a 4x4 gauze, you can wipe the blood out of the way and secure the airway. Once you've made the cut, a trick. Back in the days when we had acute epiglottitis, you all remember that. We would go into the operating room and the whole larynx was swollen and we couldn't see anything. What you do is you put your hand on the chest and you push hard on the chest and you put the tube where the bubble comes out. It sounds basic, but it works on a cricothyroidotomy and it works on just severely traumatized laryngeals where you can't see anything because of the blood. But by using the chest compression, you can follow the air bubble.
Amazing. And thank you for the tip. And Dr. Rajiv, do you have any comments?
Yeah, see, I wanted to ask Dr. Jerry, in which scenarios are you doing tracheostomy for a child with severe BPD? What are the latest indications to do tracheostomy for BPD?
Can you repeat the question a little bit louder for me?
Yeah, because now as we deal more with very tiny babies, the indication to do tracheostomy for BPD, it has been changing. So in your experience, I wanted to know, how do you select those babies on what criteria to do a tracheostomy? Because I know it helps them immensely. Once you do a tracheostomy, the ventilatory pressures come down very fast. So in which situations would you recommend tracheostomy?
Well, there are a couple of relative indications. And some children, you just cannot keep them intubated. They move too much. And there is a trend not to paralyze babies anymore. They just don't want to. They'll sedate them. They'll put them on numerous drips. But in our institution, they just won't paralyze a baby. And so we have children we cannot keep intubated. And each intubation is a traumatic event. And some of those children, no matter what their BPD is, will trach them. And we'll put the high pressure Shiley cuff in them. But you're right, the indications are changing. And one of the good things about that is we can rebuild almost anything now. So if you have a child who's improving with an intratracheal intubation, we used to say, an adult 2 weeks, you trach them. And a neonate, it was 2 to 3 months. You can probably go longer if you need to, because neonates tolerate it better. And if they get a stenosis, we can fix it. And that's a limitation we had in the past. We don't have that limitation now.
I had a similar experience recently when we had a patient in a hospital, and the same advice was given to us that we can keep the baby intubated for 3 to 4 months and then decide if needed. So appreciate that advice as well.
Yeah. It's amazing how resilient babies are. They were meant to survive. And it's, it's wonderful when you can look in a larynx that's been intubated for 3 months and you can't tell it. So, but it was a small tube. That's the caveat. The caveat, it has to be a small tube, and you have to accept the air leak. And so with ventilators, you can adjust for the air leak. And it's really funny. We'll see a resident with a small tube, and they'll be getting more out than they're putting in. How can that be? And well, the child's breathing around the tube, and that's such a wonderful thing to see.
Yeah.
I can comment on that regarding the BPD.
Today, Dr. Jerome, your
I'm sorry, Dr. Rajiv. I was going just to comment on the BPD children. We usually get a lot of them referred to the pulmonary section. So I do agree totally to have them tracked after a couple or 3 months, especially those with severe BPD that that their lungs are quite damaged for a while and they will be needing the trach for a long time. I do have a child who's almost 2 years, and I can say I'm now able to wean him off the trach gradually after 2 years. He was a neonate 24 weeker, and he had all the complication of being a neonate. And just now I'm being able to wean him from the track. So he wouldn't have had this process of healing the lung without the track, I could say. I mean, he could have been intubated for a long time for no reason. Tracks help a lot, and he was on oxygen for a long time. So having tracheostomy in early stage is very, very helpful for the healing of the lung and the development of the lung. Sorry, Dr. Rajiv, I interrupted you.
But you're absolutely right.
Fatima, what I found was when we track these kids a little bit earlier than 3 months, the ventilatory pressures go down immensely, at least by 30%. So the vicious cycle of pressure and lung damage, it comes down. So in all the 24 weekers I've seen, suppose we take a decision that this has failed 3 times, re-intubation, and say, okay, we're going to track him. I found these kids do quite well once they, on a tracheostomy tube, the airway resistance is less, the baby breathes more freely, and once the kid grows up, the BPD also settles down further. So should we really re-look into our policies for re-intubation of a child with severe BPD? Because the airway resistance and the ventilatory pressures go down immensely once you track the kid. I've seen that off and on. So I want both of you to comment on this, Dr. Jerome and Dr. Fatima. Have you looked into that area that once you track the kid on high pressures in BPD, the ventilatory requirements do go down?
Dr. Fatima, you go first.
I go first, okay.
But Dr. Jerry, we have one more dignified person sitting very quietly. Dr. Dani Reddy is in this meeting. Shall we call him also, because he was the head of department and part of my book. So he wrote the chapter on very low birth weight BB. So I think Dani Reddy is watching this very ardently. Can we invite him to participate in this issue of should we track the baby earlier in severe BPD when we know that he has failed extubation 3 times? That is my question. Fatima and Jerome, what do you feel about this? Because I think the pressures go down immensely once you track the kid. I've seen that happen.
I defer to Dr. Thompson.
Thank you, Dani Reddy. Welcome. Let me introduce you first. Let me first introduce you. We are extremely pleased that this conference is blessed by such great people. I was surprised to see you. Dr. Dani Reddy is head of department in Memphis, a neonatal intensive care unit, where Dr. Jerome also works. In fact, I got Jerome through Dr. Dani Reddy. He's my teacher and wrote and a very exponent on the chapter on meconium aspiration which you wrote. So Dr. Reddy, please add it to our discussion. And
I share your concern about high pressures, and should we take earlier. I think Dr. Thompson will tell us that tracheostomy is not without risk, and it requires a multidisciplinary team that's well versed in managing tracheostomy, and most of the facilities may not have that level of expertise. So I think it's a constant struggle between, should we do trach early or later? In newborns, I think we have traditionally waited longer. We don't entertain the idea in our unit till they're 42, 44 weeks post-menstrual age. And at that point, we start having a dialogue with Dr. Thompson's team. And we do pay attention to how high a pressure the baby needs, and if it's too high, then the leak is high. So I think the Dr. Thompson's team will say, we won't trach, if the pressure generator is too high. So it's a vicious cycle. So I think like most of the things we do with BPD, it's a very frustrating disease. Sometimes the treatments are also, aggravating the problem. So it's a matter of risk and benefit, and each team at their respective hospitals need to look at what is the expertise of the team there, and also they have any experience, you know, with the tracheostomy, not just the physician team, but nursing is very critical. And so I think it's not as simple as we like to make it look, you know, Rajiv. I know I didn't answer the question.
Maybe I should say a small comment on that, being a pulmonologist. I would say I would prefer a tracheostomy than an ET tube, because the whole lung mechanism change with the tracheostomy compared to the EET tubes. And the breathing effort would have much less with the tracheostomy tube compared to the EET, and you would have much less resistance in the track with the tracheostomy tube compared to having an ET. And this is why you go much lower pressure with a ventilator, because you would have much better lung mechanism. It is pathophysiology of the lung. I hope
totally
Dr.
agree.
Jerry agree with me.
I totally agree. I couldn't have said it better.
But now what I'm coming to is this I've seen time and again. Should we revise our criteria to do a track when we have the facility? That is, suppose you don't have to wait for the pressures to go really high, the lung to be in a bad shape, because the whole airway resistance and mechanics change with the tracheostomy. The baby breathes more freely, and probably we can shift him. I've seen that at least a month difference occurs between children who have been intubated for 3 months if you took a decision earlier than later. A month difference in getting him off the vent. This I've seen. I don't know what Dr. Fatima and Dr. Jerry and Dr. Dani Reddy say about this.
All right, one comment about tracheing very, very early. Trach tubes come in numerous sizes. A 2.5 neonatal trach tube is almost impossible, if not impossible, to keep open for nursing staff. And a mother couldn't do it. A 3.0, it still tends to plug with thick secretions, but a 3.0 has a lot of resistance in the ventilatory capabilities. A 3.5 and a 4.0, you start getting into an airflow dynamic where, you know, the surface area is large enough to be able to have a sufficient tidal volume. The biggest problem with the trach tube is that there is a risk of the trach tube falling out. And so, you know, during this COVID crisis, we're here in the United States, we're shopping on Amazon, and every day we get a cardboard box of something. Well, the way we do our trachs here is we open them like you would open a cardboard box. We make an H flap in the front wall of the trachea and sew the trachea to the skin. Because one of the more common mortalities and morbidities from a tracheostomy is for the trach tube falling out. So we actually sew the trach tube flaps to the skin so that anybody can change the trach tube. But with trach tubes, they can also create a false passage. And so it does, as Reddy was saying, there are a lot of issues about building a team to make sure that you take it well. After about 3 weeks, the trach tract is very well matured, and it's very difficult for you to put the tube in the wrong place. But we still lose children to plugging. And so there are issues with the trach tube, but doing it early is one of those issues that I delay, because I just won't do it if they're hitting pressures over 35, because I prefer the Bavona trach tube. If they are persistently extubating themselves and cannot be ventilated well and being re-intubated, then I'll switch and put a Shiley in if they require high pressures, because the Shiley will take me up to 50. If they leak there, you just keep turning the volumes up and anticipate the leak. And we've had some horrible leaks where their lips are fluttering and things like that, but we were adequately ventilating the lungs.
Dr. Reddy, can we look back into our data and see whether could we have taken this baby to track earlier? Can we look back into our data?
Yeah, I think there was a study that came out from the National Children's Hospital Consortium, looking at the tracheostomy in BPD and their experience. I think there's quite a bit of variability among the institutions when they're doing the trach. And it also depends on their level of comfort between the surgical approach versus the regular approach. Unlike adults where they routinely take patients, if they are more than a few weeks or on ventilator. Neonates we have traditionally managed without the tracheostomy for quite a bit of time. But I do hear the concerns the pulmonologists raise. I think it's just the risk benefit, and no single center will have patients to answer this question, Rajiv, unless NICHD looks at a multi-center way and address that, and trying to get a consensus among pulmonologists, neonatologists, ENT, and often we need to get the cardiologists in because they have pulmonary hypertension. So my experience has been trying to get 4 different services come to a consensus. It's like, Security Council working on a resolution.
Thank you, Dr. Reddy.
I have a question for Dr. Jerry. In terms of parents in these difficult procedures, how do you approach them? I mean, the outcome is not Gary. I mean, for example, where you have an antenatally diagnosed tumor or something major where you want to do an exit procedure. So how do you counsel them? Because the likelihood of failing is as high as succeeding, or even more probably.
Well, we do. We present it to them as the avenue of last resorts. These children are probably going to die if we don't do the exit, because they won't survive a regular vaginal delivery. And so I just wrote a paper. It was very interesting going back into history where OB just considered this a terminal disease in the 60s and 70s. And it wasn't until the 80s and 90s when they started doing exits. And so I presented to the parents that this is a significant operation and that there is a substantial risk of death, and that if we fail, we will fail making our best effort to save their baby. And uniformly, they all just say, please, please try, because the people who have talked to them before me have already told them the child's going to die. So that, we're coming into a situation, at least giving them a chance. And that's all the parents really want us to do, is to give their child a chance.
Following on the same question, sorry, the same
Go
issue
ahead.
we raised. No, the same issue we raised earlier about a neonatologist having a difficult airway. What is the medico-legal position if they try to put a blade in and they cause some problem?
I've been around a very long time, and I appreciate anybody of any skill level trying to help a baby. If their heart's in the right place and they've had some level of training, even if they cause bleeding or a little bit of damage, I haven't encountered a situation where I couldn't get around it. If the larynx was too damaged to be able to intubate, I trach. But I haven't seen that. I've seen lots of blood, I've seen lots of swelling, but I've never seen, a neonatologist who did any significant harm trying to intubate. That's one of the nice things. If you at least try, you feel in your heart that you've made an effort. And I support you.
Thank you.
How often in laryngomalacia would you operate the child? How often? Severe laryngomalacia.
Yeah, well, we use a couple of indices. One, if they can't maintain their sats, if they have to stay on oxygen, if they have apneic episodes, if they're retaining CO2, and if they can't eat, then we'll go in and do a supraglottoplasty on the laryngomalacia. All we do now is trim a little bit off the top of the epiglottis. We burn the backside of the epiglottis. We cut the areoglottic folds, and we burn the backside of the arytenoid, pulling them back. And that operation preserves as much tissue as possible, and it tends to work. So we go in and take out too little, because we can always go back and take a little bit more.
So, is there any other questions came up?
No questions came up. I think Dr. Jerry has had tremendous
I
session now.
want,
And
Sridhar, one last question. I am happy to see my classmate of